Before I introduce our first speaker, I have to buy myself some time here because I have to find the thing that I'm supposed to read from, and I'm so disorganized up here, but I'll find it. In the meantime, I want to share a couple of quotes with you. The first one is from John Kennedy, and he said, "Change is the law of life, and those who look only to the past or the present are certain to miss the future." So that's a reminder to us, don't get so embedded in where we are right now that we can't see where the future, what the future looks like. And then the other one I particularly like, and it's from a Californian, also became a president. There are no easy answers. We know that. But there are simple answers. We must have the courage to do what we know is morally right. What we're doing is the right thing, and we need to just keep doing it. Peggy O'Kane is one of the nation's leading advocates for improving healthcare quality through measurement, reporting, and accountability. She's a pioneer in engaging patients as partners in their own health. Since its founding in 1990, Peggy has led the National Committee for Quality Assurance. While it has many initiatives underway, NCQA is probably best known for developing HEDIS measures and report cards that help employers and consumers understand the quality of the care they are purchasing. Peggy's work has earned her numerous awards and honors, including her third appearance on Modern Healthcare's list of the top 25 women in healthcare. Wow. I did see that recently, and has frequently been named to the magazine's list of the 100 most influential people in healthcare. We're delighted to have her with us today and look forward to hearing how she believes health information exchange and healthcare reform are transforming healthcare. Please welcome Peggy O'Kane. Thank you.
Good morning, everybody. How are you? Good. So I'm going to start with a pogo slide, and now this is a little confusing because I always thought that pogo said the thing that's at the top there. We are surrounded by insurmountable opportunity, and so I was looking for that, and we went on Wikipedia and we found this whole entry that said people think that Pogo said this, but we can't find it anywhere. So I also put up the other one, which always comes in handy in healthcare. So hopefully that's not going to be true going forward, because we have so much important work to do. So I'm really pleased to be here today. I thought I would start with kind of a plea for how we have to get healthcare costs under control. They're strangling our country, and no matter how you look at it, look at the crisis of governance that healthcare costs are creating. I mean, healthcare costs are the major contributor to the deficit projections for the future. Look what it's doing to households. We always read about healthcare costs are the major cause of bankruptcy, and half of the people that go bankrupt actually had health insurance. Employers were down from 65% a few years ago of employers providing health insurance to 58%. So we've got to do something about this, and that involves all of us in the system. I just thought I don't know, how many of you saw this on the web, because I found it very compelling. It's a comparison. Now, Switzerland started universal health care in what year is that? 1980? I think that's the year they started. They didn't have it. They were one of the few developed countries that didn't have it at the time. And at that time, their costs were about the same as ours when they launched the program. But look what happened over the years. That orange wedge represents the cumulative difference in healthcare spending between us and Switzerland. And Switzerland has a really good healthcare system, and people are very satisfied with it. But they compared to us, if you adjust for the size of the population, we're talking about nearly $15.5 trillion over that period. So what could we have done with that? Well, for one thing, we could have transformed our $11.6 trillion federal debt into a $3.9 trillion surplus. Or we could have reduced our taxes, which is much more likely. We could have sent 175 million students to college for 4 years. We could have covered an area the size of South Carolina with solar panels. Or we could buy everyone in the world 4 iPads, which we wouldn't do. It's a stupid suggestion, but I got this out of the thing that was on the web. So I just want to make the case that I think we know now, and this is one of the exciting things about this moment in time. We know that we don't have to trade off cost and quality. We know it's possible to achieve the triple aim. You know, the triple aim means, means lower costs, better health outcomes, and better patient experience. And it's Don Berwick's construct. And to me, it's a great thing for us to focus on. So I like to call out Denver Health. We gave them an award last year. We gave Patty Gabo an award. She was the CEO of Denver Health, and she's just retired. Denver Health is the Public Health and Hospitals Corporation of Denver. So like any public corporation, it's been under tremendous financial pressure. And what they did was they embraced the challenge of cost containment. They're serving way more people than they ever have, and their budget has remained relatively flat. And yet, they're one of the top 5 achieving hospitals in the country when it comes to patient outcomes. And they've done that through Lean, which used to be called the Toyota Production System. It's the kind of effort that we need to see more of in healthcare. But we're not going to see more of it until we fix the payment system, because unless you're like Denver Health and Hospitals living on a fixed budget, if you do things to become more efficient and drive out waste and unnecessary costs, you will go bankrupt or you will suffer economically. So we need to get to a point where when you become more efficient, you actually do better. And I think that's what the goal is of a lot of what the Affordable Care Act is driving towards, what purchasers want to see, and so forth. Now, you know, I'm the head of a quality organization, and you know, I often wonder as I'm making these cost pleas what people must think about that. The chairman of my board said to me the other day, who better than a quality organization to be carrying this flag? And I don't think I need to really justify it, but let me give you a couple of reasons why we should care about costs if we care about quality. One thing is that if you look at the trends in insurance coverage, you see these high deductible plans are really out there, and employers more and more are going to high deductibles as a way of just passing the burden on to patients. We also know that when those deductibles are right up front, people don't go and seek care, and people don't take their medications if the benefit design is not right. So it's a very real threat to quality if we don't get costs under control. So I've been giving a lot of thought to how we ought to be thinking about the future of health policy, and one of the sort of planks in my personal platform is that all healthcare providers, and I don't mean just physicians, but I'm calling physicians out here, they should be part of somebody that's accountable for costs and quality. So, you know, in Kaiser, that's one type of situation where the doctors are rewarded for becoming more efficient. Medical groups, you have many in California, and my remarks today are really tailored to California. You have a lot of very advanced medical groups in this state that can be accountable for costs and quality, that can manage the whole spectrum of resources. There are integrated networks emerging around the country of freestanding providers that are networked together through IT, and I'll talk about one of those today. And you know, we need to think about some specialties that may need to stand alone because they'll work with other ACOs and so forth. But I think that this idea that everybody needs to be part of something that's accountable, where we benchmark the quality, we benchmark the costs, and we reward accordingly, That seems to me to be the way to go. Otherwise, I think regulatory attempts to set ceilings and so forth, it seems to me always kind of fall short. And where you allow people to be accountable for quality and cost, and you allow them to benefit from the good that they do, both by having the market be clearer about who's doing a really great job, and also by allowing them to keep some of the economic benefits. That's really where we need to be. This little thing just went too fast. You know, there are many problems with any kind of solutions that you think about in healthcare, and I'm putting a couple of these up here because I'm going to talk about them some more. But one problem is the patients themselves cross boundaries. I'm going to show you some data from Oklahoma, but my farm studied patterns of use of Medicare beneficiaries. This was a while ago, I don't know, 8 years ago, I think. But she found that the average Medicare beneficiary sees 2 primary care doctors and 5 specialists in a year. Now, that is a formula for problems. And so I strongly believe, and this is controversial in some quarters, that patients also should be part of the solution. They should be invited to be part of an accountable entity, and they should be rewarded or, you know, not rewarded if they choose not to. Patients also drive outcomes. So we know that the best health care in the world with an uncooperative patient is not going to work. So we need to figure out better ways to engage patients, and so that's a big agenda item. So I just wanted to show you these data. This is from Tulsa, because I'm going to talk about Tulsa's Health Information Exchange today a little bit, because I think it's one model, and I like it that you have the sophistication in California to understand that you have a lot of different solution sets that you need to have for health IT. And I spend time going around and visiting interesting projects around the country, and Tulsa is a beacon community that's doing a lot. It's also a comprehensive primary care initiative test site. But look at the number of patients that are shared in 6 large organizations in the Tulsa market. So you can see that there is a lot of patients crossing boundaries, and that really is an issue. Now, what they're doing in Tulsa also is an extremely fragmented market. It has a few hospitals that have medical groups, and so, not medical groups, clinics and so forth, but mostly it looks like the East Coast, very, very fragmented, not a lot of integration of care. And so what they've done in Tulsa is they've taken their HIE work and created the integration across the community. I don't actually think that's necessarily the right solution in California, because I think within integrated organizations, they can create HIE for themselves that will go beyond what we're able to build uniformly across the community. And I don't think we want to get in the way of that kind of thing. So. And let me just say a few things about NCQA. You heard us called out for HEDIS, which I know some plans call it heinous. And you know we accredit health plans. I'm pretty sure you know that. We accredit many health plans in California. And in the last few years, we've been doing a lot of work on creating models of accountability and integration that can be used for achieving what we want to see in the delivery system. And so we have accreditation of accountable care organizations. That's our newest program. That's brand new. That has 6 accredited entities. We have patient-centered medical homes at the bottom there. This has been a huge success, and we've had many states building multi-payer initiatives around medical homes, paying for care management, connecting the practices, embedding care managers in the practices or that go among the practices. We've seen amazing results in these more fragmented communities just based on medical home. And then our newest program in the middle there is our patient-centered specialty practice program, and that goes from Are you a good partner to the medical home that you work with? Do you communicate back and forth? To when you case manage your patients, as in oncology, for example, are you capable of doing a good job with that? So these programs are out there. They only work if there's a community that comes together around them and changes the payment system. For very understandable reasons, primary care practices are not interested in doing what it takes to become a patient-centered medical home unless there's some reward for them to do it. And we know that, I think practices are enslaved by the payment system, the visit, the tyranny of the visit, when we can do things by email, when we can do things by telephone. If you can change that around so that people don't feel that they're taking it out of their own bottom line when they do these things, you can get a lot done. So we're very proud of this. And Medicare and Medicaid in many cases is paying extra to patient-centered medical homes, and Medicare is using it in a number of demonstrations from CMMI. So we're very proud of this work, and we're very anxious to evolve it. I was very happy to hear Pat Powers yesterday talking about some possibility of using it in California. It's good stuff, and I feel very humbled when I see what people actually do when they embrace the paradigm of population health management and care management. It goes way beyond the standards that we set. Let me just go back for a second. Let me give you an example. So there is an oncology practice near Philadelphia, in Crozet, Pennsylvania. Crozet Medical Center in Philadelphia. It has 8 oncologists, and they actually embraced the medical home model a few years ago, before we had the specialty practice model. So what they did was, as you may know, our patient-centered medical home has a couple of features that are really very important. One is enhanced access. So people can call 24/7, and you have to have a way to route them to some place to get taken care of. And the other part is care management, which they put a lot into. In 1 year, they cut their ED use by 68%, and they cut their hospital admissions by 51%. And if you have a loved one that's had cancer, the last place you want to be is in the emergency room or in the hospital because your meds went haywire. So it's a great quality story, and it's a great cost story. And the only bad part of that story is they're losing their shirts because they get paid less, even when they visit patients on the outpatient basis. So, we actually just got a grant from the Patient-Centered Outcomes Research Institute in Washington, which is doing comparative effectiveness to test this model with a number of different oncology practices and payers that have said, we will pay case management fees and we will pay for outcomes. So we're very excited about this. It illustrates, I think, what people do with our humble standards, if you will. So we're really looking forward to getting this to work. So I think that this just shows some of the different models that we're seeing emerging now about how people are organizing themselves to get care more integrated. And my basic message about this is one size does not fit all. And so we have to be creative, but there has to be this common bottom line of accountability and, I think, of benchmarking results. So let me just say a couple of words about e-measurement. And, I think e-measurement to me is kind of the tail of the dog. It's what do the electronic systems do at the point of care to actually allow you to give the patient the right care at the right time? That's the bigger question. But at the same time, we would like to see some more information than what we currently have in the state-of-the-art of quality measurement, which is really not what we all want to know. We want to know a lot more. Oops. So, I think that how many of you are doctors in this room? Okay, I don't need to tell you, but how many of you are nurses? You probably have the same take on this. There's a lot that a lot of reasons why we'd like to have our electronic medical records be able to tell a more holistic story about what's going on in practices. So, we don't get clinical detail and claims, and if you're with a health plan, anybody from a health plan? You know what it is to, nobody from a health plan, to chase results in records. Measures of efficiency, which we're working on, overuse measures, they require clinical detail. The desire for new types of measures like patient-reported outcomes, which of course is what everybody wants, right? That is going to require information from the medical record. Desire for patient-centered episodic measures. Manual review of charts is a pain, and we know that some medical records aren't much better. Reading a medical record through is not any more fun than reading on paper. In fact, it might be less. So we are working under contract with the federal government on some very interesting measures. I'll just tell you about a couple. Total time in range for patients with atrial fibrillation. That's an ONC, Meaningful Use 2 measure. 2 measures on the content of Medicare annual wellness visits, closing the referral loop, overuse of DEXA scans, which is a choosing wisely measure, functional status assessment for rheumatoid arthritis and asthma. So you can see that there's a definite difference qualitatively in some of the information that we're going to be able to get once these are widely used. And I should say these measures are meant to be used in practices, not at the plan level, because plans at this point, they don't have, except with the exception of Kaiser and group health, most plans are not getting enough consistent electronic information from the practices. So, as I sort of puzzle about, I have my personal thought process about healthcare reform, I think we need accountability at every level of the system. And payment reform has to be, we all need to be aligned around the triple aim. That needs to be what everybody in healthcare wakes up with every morning. This is, I think we got that one slipped in between. This is where you can get information for our diabetes measures currently. And what it shows you is that for many of them, you have to go to the EHR or a paper record to get the information. So it's just showing you that what you can get out of claims data is a very limited and uninteresting story. And that the more interesting the story gets, the more the EHR is going to be able to help you. So one of my observations after many years of observing data, I hate to say how many years, but I remember when the CHINs, how many people remember the CHINs? Health Information Networks, Comprehensive Community Health Information Networks. Just having data flow somewhere and land on somebody does not mean that it's going to do any good, okay? So that's really the point. The information is going to be used by the delivery system to advance its goals. And so if its goals are to upcode or to make sure that, everybody gets everything possible, then you've seen these articles about EHRs driving costs up. Well, if we have an incentive system that rewards that, that will happen. So we have to have the accountability structures that will then drive the health IT to meet our common goals. So that feels like an important concept to me, that the goals of the delivery system will drive the use of health IT, and that the health IT can support our public goals if we align the incentives correctly, so all the way down the line. And then I think we will see the full blossoming of what we can get from health IT. So so we have a lot of data today, but we're not there yet on cost and quality. And so, we have these early efforts. We have the pioneers, they've been That's been kind of a rocky road, I think, the Pioneer ACOs. We have shared savings ACOs and so forth. We're kind of beginning to walk the path, and hopefully we will get to a point where we have the incentives aligned, where everybody is working to get quality, affordable health care and the most health for the health care dollar that we can possibly get. So again, I think I've made this point, that integrated systems will have their own HIEs, and then we need to have information that crosses boundaries when people go from an integrated system maybe to some subspecialist that's not within the system, or when they're on vacation, or there's a car crash or something like that. We need to have both of those things. But what about all the Californians, for example, that aren't in an integrated system? So, again, I'm making the point, I think Tulsa's community model would not be a good fit statewide, but it might be a good fit in some of your more rural areas. So community models, I think, make sense where the delivery system is fragmented and there's very little hope that you're going to get the kind of bricks and mortar and integration of the delivery system, because it doesn't make sense. The population's not big enough to support that. But I want to show you this because I promised David Kendrick that I would tell everybody I know about what they're doing, because I was so impressed with it. And I think it's actually very useful. We just had him come to our board meeting, and our board was completely fascinated. So, and if you invite him, I think he'll come or do a webinar for you. So another point is, how do we integrate the population health goals that we have with these goals of the individual system? So a community model, if it's just the community, and I've said this to David, I don't know how you parse accountability. What if the community gets to a certain level and it's not quite where you need to be? How do you make it happen unless you bring it down to the next level and you can actually say, well, you ABC system, I see your costs are very high and your quality's not that good. So therefore, I'm going to do what? What am I going to do? I'm going to, I don't know. I think this is part of what I have not worked out, and wonder if people have thoughts about that. So again, I think the magic is in giving people the right data at the right time for the right purposes, and not giving them everything that they could possibly have flow through their electronic systems. I think I skipped. Yeah, so again, I think I've made this point. What about your rural areas? Do you have IPAs that can become a basis of integration? I mean, you have telemedicine experiments going on here. I think that there are incredible possibilities these days about really bringing up what happens in rural areas to a standard that anybody would be proud and pleased to use. But I think ultimately my point is that you need a mixed model, and I think you're way ahead of me on that. So let me just show you a couple of things that are happening in Tulsa. So this is just showing this world still exists, of course. All of this data. Now, if you're the doctor office, good luck with that. You're supposed to be accountable for that? I don't think so. So what My Health has done is they've got the payers. They've got Medicare, the Blues, which is the largest payer in Oklahoma, and Medicaid, all putting their claims data in. They've got lab and pharmacy claims data, and they've created this cloud. And the cloud, different practices can get apps to get pieces of information, and they go around and they detail to the practices the uses that they can have for this. And I have been there and visited them, and the level of excitement in the community is really amazing. They also have many patient-centered medical homes. There are 75 of them in the Comprehensive Primary Care Initiative, and they are very much aware that they are accountable for quality quality and costs, or Medicare will pull its $20 PMPM, which is what they give on average in that demonstration. So there is a motivation to really do something here, and then there is this amazing technology that they have built through federal grants, really. This is something that goes to the provider. So the red is things that require immediate attention, the green is good, and the yellow is, might want to take a look at it. They even have something for patients. This is built off Archimedes. Have any of you heard of Archimedes? This is David Eddy's modeling, where it's for cardiovascular. This is for cardiovascular. And basically what it'll do is give you a customized set of things that you might do, and the net benefit that you would get for quitting smoking versus going on statins or something like that. So it's really impressive to see every little piece being addressed here. And I'm not being paid by my health. So the last piece of the puzzle is patient engagement. And I think this is, we're very excited. We have entered into a partnership with the Gordon and Betty Moore Foundation to come up with a strategy for patient engagement, and we were just notified this week. But the patient is a missing piece of this, and I think we don't know how to do it, and we need to be incredibly humble. We know how to yell at people, and that doesn't work, as we all know. So on the cost side, I believe that patients should be rewarded for agreeing to play their part of being part of a system. They should get better coinsurance. And if you saw the new Medicare Essential proposal that came out this week, that's one of the things that they have. If you go to a patient-centered medical home or an ACO, you get better coinsurance. So let's get this alignment. We've gone through all the stages of the payers fighting with the providers and the patients and everybody, all the different permutations of who's fighting whom. How about if we get everybody aligned towards the national goal of quality, affordable health care? So this is kind of a gross picture, but how do we motivate patients? There are people that know how to do this, but it's not us, okay? How do we help people feel good about, how do we communicate a positive health and not scream at people or tell them that they're sick all the time, There's a different way, and I think if you've watched what goes on with behavioral economics, it turns all our ideas on their heads about how people think about the way they spend their money. And I think it's really probably more complicated in healthcare. So I think I made that point. So, let's give back some of that money. Let's give back the money in the high deductible front end there to patients that are willing to be part of a system, work on their whatever their health issue is, take their medications. Let's get them aligned with us. And this is a whole new area that hasn't been tried. I worry that it's going to be demotivating for people, that it's going to feel like a stick. But I think we need to explore this because they're paying too much out of pocket right now in the wrong place. So that's the end of my remarks, and do I have a few minutes? Yes. Okay, not very many. So I didn't plant any questions, but I should have. Is somebody walking around with a mic or? Okay. If you could say who you are and who you're with. Then.
Very impressive presentation.
Oh,
thank you so much for coming and presenting such an important future for us. I'm Jessica Nunez de Ibarra, the California Department of Public Health. I'm currently working with a large group in our chronic disease program prevention to develop a California chronic disease prevention plan. We may retitle it as something more positive like a wellness plan, but that's still to be determined. Next week it will be online. We are using the framework which was discussed yesterday, the Let's Get Healthy priorities in the area of chronic disease, which are the majority of those priorities. We've built out short-term, interim, and the long-term indicators that were previously adopted. We've put the middle in, I guess is what I'm trying to say. We are going to try and put in there our best knowledge as a team at the California Department of Public Health about how to do that better, because we agree with everything said. All the tenets that you've described are in that matrix. I'd like to have a conversation with you maybe offline to make sure that the HEDIS measures that we include in that sort of drive what you're describing. We intend to put it online for stakeholder and public input for 3 weeks, and then we'll finalize it, get it done, because we don't want to spend a lot of time planning to plan. But then we hope to have a meeting in January of 2014 to create the policy agenda in terms of what really resonates with people after they've had a chance to look at it and to see what really works and what may move the dial collectively. So I'm sharing that with you and would love to get your feedback about things we may want to consider in that proposal.
Well, thank you very much, and be happy to take a look. I didn't say anything about some of the major drivers of health, which have nothing to do with health care. So let me just go on record as a big admirer of Bloomberg and what he's been trying to do in New York. And you know, they've had weight loss across the board, children, adults. You know, I think California has always been a forward-looking state in terms of your smoking policies and so on. So I think more of that. You know, it is crazy to think that the healthcare system is going to fix what people are being stimulated to do every day. That's bad for them. And if you ever watch sports, I'm sure all the men in the room watch sports, or most of them. It's shocking to me what you see advertised on sporting events. And you know, people, I mean, this stuff works or they wouldn't do it, right? This advertising works, advertising to children. My daughter is over 30, and I'm getting envelopes from Camels with coupons for discounts on packs of cigarettes. I thought that was illegal. It's not illegal. So I think that whole public health and taking a stand on what's healthy for Californians, that's how you're going to become the healthiest state. But I'd be pleased to talk to you about your other work there.
Thank you for reaffirming what our actual focus will be.
Okay, great.
I wanted to let you know we are trying to make it really broad, kind of the bigger, the whole map, and then together decide where we're going to go.
Great.
Hi, Julie Silas from Consumers Union over here.
Hi.
Hi, morning. Thank you so much.
Thank you for your work.
Thank you. I wanted to ask two things. First, I wanted to thank you for the work on patient engagement. That sounds very exciting, and Consumers Union is very hopeful, especially to have you all get engaged in that issue. One thing, when you originally asked who was in the audience and no one raised their hand with the health plans, that's something I think is going to become more relevant and a big hurdle we have to get through, that very few, if any, are here, because when we think about the new health benefit exchanges and the role that insurers are between the policymakers and the plans in a new and innovative way, and the challenges and the pushback around quality and cost issues, or the direction in driving those conversations with the plans than with providers, because it's great that the providers are doing it and it's great policymakers, but the in-between right now, there's a disconnect. So I'm wondering what you all are thinking about doing, or what efforts you have underway to engage health plans in that issue.
Well, we've been talking to everybody, as you can imagine, about this. So we've been talking to the exchanges, the states themselves, and in fact, I just talked to Jeff Rideout, who's the CMO at the exchange here. You know, we think California is being pretty bold, and you know, there are a handful of states that are really trying to use this to drive a value agenda. I think that in our minds, how you present the data is going to be crucial. Behavioral economics, again, tells us that if you give people too many choices, or you don't arrange them in a way that they can understand, they will just shut down and they'll pick the cheapest premium, and that's it. And then they'll be disappointed when they find out how much comes out of pocket, for example, and so forth. So what we hear from a lot of plans is that there are going to be a lot of narrow network offerings. And we're kind of putting on our seatbelts here because it feels like the old days with narrow network HMOs and so on. And I don't know that the public is ready for this, but the public is ready to pay less, that's for sure. And so it'll be interesting to watch it play out. And I think frustrating in a way because, you know, we have data on a lot of the plans that are going to put out narrow network products, but the data may look quite different for the narrow network than it does for the whole thing, and yet we're going to have to wait some time to get the data that we need to have the actual data on the narrow network. And so part of what we're advocating is a lot of CAPS surveys right away to compare to the general CAPS, and we'll see. You know, I'm very excited about the exchanges. I hope we don't blow this opportunity to have people actually shop in a way that serves their interests best and serves all of our interests best by driving the market towards quality, affordable health care.
Yes. I'm Dr. Steve Hansen. I'm a medical director of a small hospital, and I loved your slide about Switzerland. They get more infrastructure and more quality care than we do for 30% less, and I think it's good for people to know how they do it. They negotiate a fee schedule every 2 years. It was enacted by a national plebiscite, something we can't do here, over the objections of their insurance industry and their pharma and everybody else.
That's interesting. Thank you for letting me know.
But my question is, how much does health IT play a role in that? And
in Switzerland?
Yeah, and isn't it really the fee schedule structure that's negotiated that drives everything else?
Well, I'm sure the fee schedule has a lot to do with it. And as you know, I mean, we're seeing a lot about prices these days, right? I don't know. Did you all see the New York Times yesterday, the article where the federal government is publishing differences in DRGs that are shocking? And Time Magazine, you know, so there's kind of a building momentum on the issue of price. I don't know the answer. I do know that Switzerland is very well wired. So, you know, they're very orderly people, right, in Switzerland, and their healthcare system is also very orderly. So I think it's probably some of both. And also, I think they don't have the disparities in wealth that we have, which I think also has an impact on the health of people. So, you know, they do start with a number of advantages that feel beyond our grasp, I admit. All right, one more, I guess. Am I okay? Well, I have 1 minute, okay, so I can, depending on, okay.
In the Tulsa system, looking at the Tulsa system, Oklahoma has a well-established community behavioral health system, community mental health centers, but I don't believe that's part of the network, is it? And do you know how they're dealing with behavioral health?
I don't know. I don't remember any discussion about that. What I will tell you, which I didn't tell you before, is that they have a saying there, thank God for Mississippi, because they're always like number 49 on any indicator of the health of their population, and Mississippi seems to be holding its own there on the wrong end of things. So, but I don't know that they've gotten to that part. But they have really incredible referral electronic connections between primaries and specialists, and they've been able to show that the referral process is completed in like more than double the percentage than it used to be. So they're building all these pieces out all the time, and I'm sure they'll get to that, but I don't remember hearing anything about that. So I think my time is up. Thank you so much for your great questions and for your attention.